Hello friends, welcome to Healthwizac Medical Concepts Simplified. In this video, we will learn about diabetic ketoacidosis, also labeled as DKA. DKA, as the name suggests, is a clinical condition diagnosed with the presence of triad of diabetes, that is high sugars, ketosis, that is presence of ketone bodies, and acidosis. It's usually found as first presentation of type 1 diabetic patients but can also be present in type 2 diabetic patients. Before jumping onto the topic, let's first quickly understand the pathophysiology responsible for maintenance of normal sugars in blood and why it's deranged in diabetics, causing DKA. Glucose equilibrium is controlled and organized at following organ levels: neural inputs, neurotransmitters, hunger hormones, and hypothalamus in the brain. Liver, which is responsible for glycogenesis, gluconeogenesis, glycolysis, and glycogenolysis processes. Skeletal muscles and cells for utilization and uptake of sugars. Pancreas, which is responsible for secretion and regulation of two important hormones, that is glucagon in the alpha cells and insulin in the beta cells, along with gastrointestinal peptides. An important point that should be noted here is that brain is insulin independent for utilization and uptake of sugars, whereas skeletal muscles and cells are insulin dependent for utilization and uptake of sugars. In normal healthy subjects, the food we eat is converted into glucose by digestive enzymes of GI tract and is made available in the blood for utilization and uptake. Blood sugars of more than 70 promotes insulin synthesis by the pancreatic beta cells, which detects sugar and starts releasing insulin. This happens in two phases, that is initial rapid phase and second prolonged phase. Insulin facilitates entry of glucose into the cells and makes it available for use. Excess glucose is stored as glycogen by liver by a process called glycogenesis. This maintains normal blood sugars. In fasting conditions or exercise, when the blood glucose level falls below 70, it triggers brain for hunger hormones, which then sends neural inputs to the pancreas, thus reducing insulin synthesis and promoting glucagon secretion. This facilitates glycogenolysis, that is conversion of glycogen stored into the liver into glucose, and maintaining the normal blood sugars. In diabetic patients, due to the lack of insulin from pancreas or its reduced sensitivity, the blood glucose is not transported into the cells for utilization and thus increasing its level in the blood. This excess glucose is removed through kidneys, causing osmotic diuresis and causing tissue level dehydration. Due to lack of glucose for energy in the cells starts deriving energy from other sources like fats and amino acids by a process called as gluconeogenesis and glycogenolysis, along with increase in counter-regulatory hormones, that is glucagon, catecholamine, cortisol, and growth hormones. During this process, ketones and acids are formed as a byproduct. This process is also seen during fasting state and giving rise to triad of high sugars with ketosis and acidosis, and thus giving rise to symptom of diabetic ketoacidosis. Primary causes of DKA or diabetic ketoacidosis includes inadequate insulin administration or skipped insulin dose or new onset diabetes. Infections like pneumonia, UTI, gastrointestinal infections, and sepsis. Hyperthyroidism, pancreatitis, cerebrovascular accident, myocardial infarction, mesenteric ischemia, pregnancy, and alcohol. Drugs like antipsychotics, corticosteroids, glucagon, interferon, albuterol, and terbutaline are also responsible for diabetic ketoacidosis. Coming on to the symptoms of diabetic ketoacidosis, they are nausea, vomiting, sometimes hemorrhagic gastritis may result in hematemesis, polydipsia, polyuria, abdominal pain, and breathlessness, giving rise to the clinical findings of tachycardia, dehydration, hypotension, tachypnea, that is Kussmaul's breathing, abdominal tenderness, lethargy, cerebral edema, and coma. Depending upon the severity of above symptoms and pathological findings, DK can be categorized into three grades of mild DK, moderate DK, and severe DK, where mild DK can be categorized by pH level of 7.25 to 7.3, serum bicarbonate level between 15 to 18, plasma glucose of more than 250, anion gap of more than 10, and patient is usually alert in mild decay. Moderate decay can be categorized by pH level of between 7 to 7.24, serum bicarbonate level between 10 to 15, plasma glucose more than 250, anion gap of more than 12, and patient is either alert or sometimes found drowsy in moderate decay. Whereas in severe decay, pH is less than 7, bicarbonate level is less than 10, plasma glucose is more than 250, anion gap is more than 12, and patient is usually found in stuporous or coma state. After understanding the grades of decay, now let's have a look at the pathological findings found in diabetic ketoacidosis. The first and foremost important pathological finding is that the plasma glucose level is between 250 to 600 mg per deciliter. Due to excess glucose in the blood, there is increased osmolality of 300 to 320 milliosmol per ml in diabetic ketoacidosis. This hyperosmolar state causes shift of water from intracellular space to extracellular space, causing dilutional effects and thus causing hyponatremia in decay. However, normal sodium levels in decay indicates more profound water loss. The shifting of fluid also causes shift of potassium from ICF to ECF, leading to pseudo-hyperkalemia initially, which is later followed up by hypokalemia once insulin is started, as insulin lowers the blood glucose and thus reduces the osmolality and facilitates reshifting of fluids from ECF to ICF. Due to dehydration and reduced renal function, there is increase in creatinine and BUN levels. Excess ketones in blood causes increased serum ketones, whereas excretion of ketones in urine causes increased ketone levels in urine. Ketosis causes increased serum beta hydroxybutyrate level of more than 3 in children and more than 3.8 in adults, which is a classical feature of diabetic ketoacidosis. Due to this excess hydroxybutyric acid dissociation, there is excess H plus ions binding to bicarbonate and thus decreasing its value, causing high anion gap metabolic acidosis in ABG. Apart from this, infections may show leukocytosis, and finally, deranged lipids and false hyperamylase levels may also be present in diabetic ketoacidosis. So friends, these were the pathological findings in diabetic ketoacidosis. Now let's finally look at the treatment part of decay. Treatment of decay includes 5 major steps, that is, correcting dehydration through IV fluids, normalizing sugars through insulin, potassium correction, bicarbonate correction, and treating the primary cause. As soon as the diagnosis of decay is confirmed, first step is the initiation of IV fluid replacement therapy, as osmotic diuresis causes significant tissue level dehydration. Patients should be started preferably with 0.9% normal saline or RL bolus at the rate of 20 ml per kg body weight, followed by maintenance points. Usual fluid deficit is approx 100 ml per kg body weight, and thus total requirement may be up to 3 to 6 liter. Nasogastric tube should be inserted in case of vomiting or altered mental status to avoid risk of aspiration. In absence of vomiting or once vomiting settles, clear water may also be given orally or through nasogastric tube. Once adequate hydration and hemodynamic stability is achieved, IV fluid should be switched to 0.45% NS or RL to avoid hyperchloremia. Once sugar level drops to 250 or 200, then IV fluid should be shifted to glucose containing fluids like 5% dextrose or 0.45% normal saline. Next step is to treat insulin deficiency through initiating short-acting insulin, preferably intravenously at a dose of 0.1 units per kg, through infusion, followed by combination of long-acting plus short-acting insulin subcutaneously or intramuscularly. Insulin infusion should be titrated to achieve hourly drop of sugars up to 50 to 100 mg per deciliter, as rapid correction can set in cerebral edema. Once target sugar of 150 to 200 mg per deciliter is achieved, in spite of stopping insulin infusion, it should be continued at a lower rate of 0.02 units per kg along with dextrose infusion to avoid ketogenesis. As insulin infusion is started, insulin-mediated potassium transport along with glucose, starts, and urinary potassium loss may give rise to hypokalemia. Estimated deficit is 3 to 5 milliequimoles per liter. Next step should be potassium correction to maintain its level up to more than 3.5 millimole per liter. In DKA, initial pseudo-hyperkalemia can be found, hence anti-hyperkalemic measure should not be started unless and until other valid reasons for hyperkalemia is evident. In presence of normal range of potassium and adequate urine output, 20 to 40 milliequimoles of potassium should be added in each liter of IV fluids. If potassium is less than 3.3, then 40 milliequimoles of potassium should be added. If potassium level is between 3.3 to 5, then 20 milliequimoles of potassium should be added. If potassium level is more than 5, then no correction is required. Next is bicarbonate correction to reverse acidosis and is indicated if pH is less than 7 and bicarbonate level is less than 10. In this case, 50 millimoles of sodium bicarbonate is diluted in 200 milliliter of sterile water along with 10 milliequivalents per liter of potassium chloride per hour. Rapid correction of acidosis should be avoided as it may result in cerebral edema, impaired cardiac function, and reduced tissue oxygenation. ABG should be checked as frequently as 2 to 4 hourly to avoid rapid correction. Apart from this, magnesium and phosphate correction may also be needed if symptoms persist. Finally, treating the underlying cause like antibiotics for infection and modifying drugs and other steps is also of prime importance. After understanding the treatment steps of diabetic ketoacidosis, now let's have a look at the complications that we find while treating DKA. The most commonest complication that we find while treating DKA includes cerebral edema. It may present as headache, confusion, and lethargy. It is usually confirmed with the help of CT scan or MRI scan which shows dilated ventricles. Treatment of cerebral edema includes avoiding overhydration and rapid correction of sugars and bicarbonates, starting patients with mannitol and facilitating hyperventilation. Other complications that we usually find includes hypoglycemia with recurrent hyperglycemia, hypokalemia, and hyperchloremia, and they can be easily managed with tight insulin control or tight insulin infusion, potassium correction, and proper selection of IV fluids while rehydration. Finally, differential diagnosis of DKA includes HHS, that is hyperosmolar hyperglycemic state, alcoholic ketosis, and starvation ketosis. Finally friends, patient education regarding diabetes, proper use of insulin and its complications is one of the key factors in avoiding complications like diabetic ketoacidosis. So friends, this brings us to the end of this topic. Hope you find this information valuable and applicable in your clinical practice. Please do like and share this video and hit the bell icon for latest updates. And for more such informational videos on medical topics, please subscribe to YouTube channel Healthwizac Medical Concepts Simplified. Thank you.